So I have only 15 minutes to talk about a vast topic like role and timing of liver transplantation in metabolic liver diseases. To start with, what is an IEM? There are many fancy definitions, but I'll simplify it. It's exactly what it sounds like. An inborn means child is born with it. Error is a loss of function in the metabolic pathway, and metabolism is breakdown of steps from food to create energy. So it is as simple as that. And the overall incidence, we think that metabolic diseases are rare, but if you look at in the perspective of biliary atresia, which is 1 in 20,000, there are some, if you took the collective metabolic load, it is 1 in 800 to 1 in 2,500 live births. The international classification of inherited diseases, metabolic diseases, which they like to call it now rather than inborn errors of metabolism, has included 1,450 disorders, which are categorized into 24 groups and 124 groups. If I show you a pictorial depiction of that thing which I mentioned, it will look pretty overwhelming like this. Coming back to the IEMs, so you have a substrate, you have a cofactor, coenzyme, or a transporter which is supposed to work and conduct with the remaining part of the pathway, and if it doesn't do it, the end product is not delivered. So what it leads to is a substrate excess, toxic metabolites, and a lack of the end product. So what do we have so far in terms of management? We can reduce the substrate load by dietary restrictions. There are some enzyme replacements that can be done, some cofactor replacements. Gene therapy and chaperone therapy is in research mode. So what is left is organ transplant. So today we'll be talking about liver transplant for non-cirrhotic metabolic liver diseases. What is the role of liver transplantation in inborn errors of metabolism? It provides the crucial enzymes to create a metabolic balance, which in turn improves the quality of life, and that means no dietary restrictions and better crisis management, less hospitalizations, and that all leads to being a more cost-effective therapy. So why liver transplantation for metabolic liver diseases? First of all, the diet is very difficult to adhere, not to mention the cost. Even if someone is good at adhering to the diet and affording the cost, you are still liable to get metabolic decompensations from intercurrent illnesses or stressors. And also, diet cannot prevent progression of extrahepatic manifestations like carcinoma in the case of GSD1, adenomas in GSD1. And the most important thing is, it is very difficult to get hold of good metabolic specialists who can monitor these kids on diet, and these kids cannot just be left on a diet. They have to be monitored. Plasma amino acids, organic acids have to be monitored and titrated likewise. So, pediatric liver transplantation, which has been a well-established modality for end-stage liver disease, chronic end-stage liver disease, acute liver failure, is also good for metabolic liver diseases with hepatic consequences and extrahepatic manifestations, with the primary being in the liver, primary source being in the liver, and it helps in prevention of carcinoma as well in the future. So hepatic-based metabolic disorders which are suitable for liver transplantation. Disorders with primary liver consequences, which is alpha-1, Wilson's, Crigler-Najjar, tyrosinemia. Disorders with mainly extrahepatic consequences, the urea cycle defects, organic acidemias, hyperoxalurias, glycogen storage disorders. And there are a set of metabolic disorders which do not do very well after liver transplant, and that is familial hypercholesterolemia, erythropoietic porphyria, organic acidemias partially, and mitochondrial disorders. So now coming to the business end of the talk, which is role and timing of liver transplant in specific IEMs. Maple syrup urine disease is a rare autosomal recessive disorder with a worldwide incidence of 1 in 185,000 live births. In the Mennonites, it is almost 1 in 380. In the Portuguese Romani population, it's 1 in 70, and in India, it is 1 in 100,000. It's caused by a deficiency of an enzyme called branched amino acid dehydrogenase. There are four varieties of MSUDs, and the classical one is one which presents with fatal neonatal encephalopathy. I can skip this. So, emergency liver transplant is not indicated. On the contrary, it is dangerous to do an emergency liver transplant because you will increase the metabolic and catabolic stress on the patient. Elective transplant is recommended in children with recurrent crisis or at risk of neurological injury, despite optimal medical management. Earlier transplantation is recommended for better neurocognitive outcomes and considered around early childhood if crises are frequent and control is poor. So if you have a stable patient, you can continue diet, monitoring the patient, and liver transplant should be offered electively if the quality of life is poor and you find that there's a risk of developmental delay or developmental damage. Unstable patients will go for direct listing for liver transplant. Family counseling is very crucial, saying that, okay, liver transplant will eliminate the dietary restrictions, but it also carries the risk of surgery, and the long-term immunosuppression side effects will come along with it. Then comes the urea cycle defects. These are a set of 4 enzyme deficiencies which can cause life-threatening hyperammonemia. Management of the urea cycle defects includes protein-restricted diet, supplementation of amino acids like arginine, amino acid scavengers, and like we all know that liver plays a primary role in ammonia detoxification, and hence liver transplant has been successful in treating urea cycle defects. So what does liver transplant do to urea cycle defects? It provides a permanent source of the missing enzyme, which in turn reduces the ammonia, and corrects ammonia metabolism, preventing hyperammonemia, crisis, and neurological damage, improves quality of life, and the best outcomes come when it is performed early before the irreversible brain injury sets in. Emergency liver transplant rarely performed with acute hyperammonemia crisis due to high perioperative risk, stabilization with dialysis and scavengers, and then prevent post for elective liver transplant. What are the indications for elective liver transplant? Recurrent hyperammonemia despite optimal medical therapy, biochemical instability requiring frequent hospitalizations, severe dietary medical therapy limitations causing quality of life restrictions, considered in early childhood, especially less than 2 to 3 years before the school-going age, so that we can control the diet better. Liberalize the diet better, because once they go to school, you never know what they're going to eat. And better performed before the occurrence of neurological injury. So again, the lifelong immunosuppression risk has to be weighed with the metabolic disease, the dietary restrictions that can be removed, and this should be discussed with the family. Glycogen storage disorders. These are a set of disorders of carbohydrate metabolism, can manifest in the muscle and liver. GSD1A is the most commonly transplanted disorder caused by deficiency of glucose 6-phosphatase enzyme. And the medical therapies so far we have are frequent feeds, uncooked cornstarch, high protein diet, and avoiding of fasting. So what are the indications for liver transplant in GSDs? Metabolic complications, which is with uncontrolled by diet, which is significant hypoglycemias. Some can even have seizures, hyperlactatemia, hyperuricemia, hyperlipidemia. Progressive liver disease, cirrhosis, portal hypertension in the case of GSD4 and some GSD3s. Hepatic malignancy, hepatocellular adenoma common in GSD1, and quality of life issues, especially poor metabolic control, poor growth, and feeding intolerance also are a very common indication for liver transplant in these set of kids. What happens with liver transplant? So you give a liver transplant and you correct the enzyme that gives better glycogen metabolism, better glucose control, prevents hypoglycemia, seizures, and you have a better metabolic control, and in this in turn will improve growth, quality of life, in the long term reduces the risk of malignancy, and certain extrahepatic issues might remain, especially myopathy in GSD3, renal disease in GSD1, they might persist post-liver transplant. Emergency liver transplant is indicated only for GSD4 when they can present like liver failure. And like we discussed, in GSD1, if there is adenomas which can most likely progress to carcinoma, they are the ones who have to be listed for transplant. Early liver transplant improves growth, nutrition, and prevents long-term complications. Then moving on to Crigler-Najjar syndrome. It's a disorder of bilirubin metabolism which is caused by deficiency of UDP glucuronidase transferase. Type 1 is complete absence of the enzyme, and this is the one which is dreaded, causes kernicterus, needs to be managed aggressively. So this is Role of liver transplant in cricoid Najjar is you provide the permanent source of the enzyme, which in turn will liberate you from phototherapy and prevent chronic stress in the long term, and has excellent long-term survival. When bilirubin cannot be controlled by intensive phototherapy and signs of neurological risk are starting to begin, that is when you list them for transplant. Ideally done before the onset of stress, easier said than done. Consider early phototherapy requiring more than 12 to 16 hours of phototherapy, and that will cause poor quality of life. Liver transplant is rarely required for type 2, and it can be managed by phenobarbital. So with these kids with cricoid Najjar syndrome, you need regular neurodevelopmental monitoring. Elective liver transplant is planned in stable children before irreversible brain injury sets in. And there are emerging alternatives like hepatocyte transplant and gene therapy. That's why some surgeons prefer doing a auxiliary just in case gene therapy comes in the future. Propionic acidemia, I think we have a case on this. I'll limit myself to not going into details of it. It's just a deficiency of propionyl-CoA carboxylase characterized by recurrent hyperammonemia, and metabolic crises include, metabolic crisis happens with cardiomyopathy, pancreatitis, neurological injury, and sometimes bone marrow is also affected with neutropenia and thrombocytopenia. LT supplies the hepatic enzyme activity, but it's only partial metabolic correction. So when liver transplant helps, it is when recurrent metabolic decompensations and poor metabolic control set in despite optimal diet and therapy. End organ involvement with cardiomyopathy, growth failure, kidney injuries, these are other indications when you should go for liver transplant. What does liver transplant change? It drastically reduces the hyperammonemic crisis. There's improved biochemical control. Cardiomyopathy and renal function can get better with time, and it's not a total systemic cure. Avoid transplant during crisis, like I said before, and consider when there are more than 1 or 2 crises in the early life so that you prevent further neurological damage. Primary hyperoxaluria is a rare autosomal recessive disorder of glyoxylate metabolism causing excess oxalate leading to kidney stones, nephrocalcinosis, end-stage renal disease, systemic oxalosis. Type 1 is the most severe one, only type that can be clearly cured by liver transplant. Liver transplant, the role of liver transplant in oxaluria is liver transplant provides the functional enzyme, thereby halts oxalate overproduction. If you do not detect them early, you might end up with a combined liver and kidney transplant because the liver will provide the enzyme and the end organ which is damaged will be replaced. Isolated liver transplant, occasionally used, especially if you're lucky and you diagnose the patient early, before the renal failure sets in, then there's a scope for doing an isolated liver transplant. Before end-stage renal disease, primary hyperoxaluria type 1, rapidly declining GFR, especially if the GFR is around 50 ml per minute or above, that you consider it, because once you transplant them, they will be on CNIs, which will further damage the kidneys. Hence, do it a bit early before it drops to 30 ml per minute. Combined liver and kidney transplant is preferred for defective liver enzymes and damaged kidneys. Early diagnosis, start conservative therapy, pyridoxine trial, and monitor renal function, oxalate burden, GFRs, and refer to transplant before the systemic oxalosis sets in or irreversible end organ damage happens, kidney damage happens. So there are the conditions where liver transplant has controversial, acute hepatic porphyrias, AIP, definitely there is some role, but in EPP, liver transplant will save the patient, but ultimately you will have to use a stem cell transplant or a hematopoietic stem cell transplant or BMT to cure the underlying condition. The hyperlipidemias, again, people have different opinions about it. It will definitely reduce the need of lipid-reducing substances, but you still have to use lipid-reducing substances, and there is an atherosclerotic risk, especially if the process has set in even prior to the transplant. I think I'm just 30 seconds to summarize. So, So what we've learned so far, IEMs do well post-transplant, especially from quality of life perspective. Avoid transplant during metabolic crisis because it's going to increase the catabolic load. Have a OLT protocol to encourage anabolic state during transplant procedure and post-transplant recovery. OLT done earlier in the course of the disease has better outcome and less complications. Transplant offered earlier for kids with IEM with nephropathy is better because of the CNI use, which further damage the kidneys. Many IEMs have specific monitoring needs even post-transplant, like in the propionic acidemias. OLT is still a cost-effective treatment despite the presence of so many alternative therapies. And newer targeted therapies may replace transplant in the future. Thank you very much. So I'm on time.
Thank you so much, sir.